Hello, everyone. My name is Sahil Parikh from Columbia University in New York. It's a privilege to be here with my friend and colleague, Dr. Bill Gray from Lankenau in Philadelphia to discuss the midterm outcomes of the Disrupt PAD3 clinical trial. Bill is a principal investigator, and in the next few minutes, we'll review the results of this groundbreaking clinical trial and also discuss its impact to our clinical practice. Bill, it's a pleasure to have you here. We'd really love to hear more about these groundbreaking data. Please take it away.
Sahil, thanks for the kind introduction. I'm excited to present these data on behalf of the investigators for the PAD3 trial and also my co-investigator and co-principal investigator, Gunnar Tepe. So this is the Disrupt PAD3 randomized control trial midterm outcomes. So as we all know, endovascular treatment for calcified peripheral arterial disease is frontline therapy for most patients over the historical surgical treatments. However, the presence of heavily calcified PAD presents a challenge for endovascular therapy, primarily because it can result in poor balloon expansion, dissections, and acute procedural failure as a result. It may impair the effectiveness of DCBs by limiting drug uptake, and stents that can be used to address a PTA failure in the face of severe calcification may subsequently fracture and complicate future revascularization. Patients with severe calcification are often excluded from endovascular treatment trials because of the confounding nature of this disease set, and the paucity of evidence resulting from that makes it difficult to guide treatment in this challenging patient population. The prior results from this trial, Disrupt PAD3, demonstrated superior procedural success with intravascular lithotripsy, but longer-term primary patency results have yet to be presented from this randomized controlled trial. Just to review, intravascular lithotripsy or IVL therapy is performed by delivering a typical balloon-style catheter into the calcified lesion and inflating it at a low pressure between 4 and 6 atmospheres. The device is then activated and generates sonic pressure waves using lithotripsy. And this lithotripsy is approximately 50 atmospheres of shock to the vessel delivered in 1 pulse per second increments. This causes the calcium to crack, and both at the superficial and deep level, and safely expands the vessel with limited ancillary destruction. Here's some micro-CT analyses from Dr. Vermani at CV Path, and you can see the pre-IVL treatment, heavily calcified vessel, and post-IVL treatment, you can see the fracture lines imposed by the IVL treatment. The PAD3 program is actually one of a suite of clinical efforts on the part of Shockwave Medical, who runs the trial and is a sponsor for all of these investigations. I'm not going to go through all of these, but you can see that there was, at least for the above the knee, there was a Disrupt PAD 1 and 2, which were exploratory investigations. The Disrupt PAD 3, which I'll talk about here, a very large observational study with almost 1,500 patients, and then other trials below the knee to evaluate the safety and effectiveness of the device below the knee, and some of those trials have already been reported. Today I'm going to speak about the Disrupt PAD3 trial, which was a prospective, multi-center, single-blind, randomized control trial. It was a trial that involved the United States, the EU, and Australasia. The objective was to assess the safety and effectiveness of IVL plus DCB versus PTA plus DCB in the treatment of moderate and severely calcified femoral popliteal arteries. The statistics were such that superiority analysis was performed for primary and powered secondary analyses. So that you can see the flow chart of the trial here: moderate to severe calcification inclusion criteria in de novo femoral popliteal lesions, about 300 patients in 45 global sites, randomized equally between IVL and PTA as a pretreatment to DCB plus or minus stent as needed to maintain the acute result. The procedural success was the original primary endpoint, and this has been previously reported. And then we're going to report the 1-year primary patency, which is a secondary endpoint, and a 2-year follow-up, since we have data on that as well. The key eligibility criterion are similar to prior trials in SFA popliteal disease, with one notable exception, which I'll point out in a moment. Patients had to be claudicants or rest discomfort without gangrene or limb threat. Their target lesion had to be a de novo SFA or popliteal. The target lesion had to be within 4 and 7 millimeters of diameter, a stenosis of greater than or equal than 70% by visual estimate by the site, a length of 180 millimeters for lesions that were not CTOs, and for any CTO, a length of less than 100 millimeters for a total of 180 millimeter target lesion length. Calcification was defined as either greater than or equal to moderate, with the definitions listed here: parallel on both sides of the vessel and extending at least 50% of the lesion, and if the lesion was less than 50 millimeters, a minimum calcification length of 20 millimeters. Exclusions are pretty typical. Rutherford 0 and 1 and 5 and 6, as well as significant stenosis of inflow disease which wasn't previously treated successfully, any target limb major amputation planning, and renal disease more than creatinine of 2.5 or on dialysis, and in-stent restenosis within a centimeter of the target treatment zone. Here are the powered study endpoints. The primary endpoint was, as I mentioned before, procedural success. So the procedural success was defined as a less than or equal to 30% lesion after balloon or IVL treatment without flow-limiting dissection greater than or equal to grade D, as defined by the protocol, prior to DCB plus or minus stenting as needed and determined by the angiographic core lab. The secondary effectiveness endpoint, which was powered, was primary patency at 1 year. Freedom from clinically driven TLR and freedom from restenosis as determined by Doppler ultrasound or angiography, and acute PTA failure requiring stent at any time during the index procedure was counted as a loss of primary patency as per protocol. So that's an important caveat here. By definition, PTA failure at any time during the 1 year period and beyond was also defined as a stent implant at the time of the index procedure. Additional 1 year secondary endpoints include ankle brachial indices and metrics of patient satisfaction and performance. The study support is here, and as I mentioned before, I'm privileged to have done this trial as a principal investigator with Gunnar Tepe. The clinical events committee ran out of Yale by Louise Gambone and Alexandra Lansky, and the safety and monitoring data management statistics run out of NAMSA nearby Philadelphia here. These are the investigators, really an all-star cast of investigators. I want to thank them tremendously for their expertise. Without them, this trial could not have been done with the same level of integrity and diligence. We have to remember this trial was done during both the paclitaxel scare and COVID, and so it's quite a remarkable feat. Here's the study flow. As mentioned, recruitment took about 3 years because of the prior delays in the larger environment not related to the study. IVL and PTA randomized equally. You can see the follow-up at 1 year and 2 years. And we have data for patency of 80% of the patients at 1 year and 72% of patients at 2 year, largely in both groups. Baseline lesion characteristics were very similar among the two cohorts. They were randomized, so we would expect that. Notable is the lesion length of about 10 centimeters. Lesions over 15 centimeters comprised about 1 out of 10 patients, and the calcified length was beyond the lesion length at about 13 centimeters for both groups. Severe calcification, as defined by the PARC definition, was present in over 80% of all patients treated. Here are the procedural characteristics. This has been previously published. Contrast volume was similar between the two. Fluoroscopy time was a little longer for the IVL. Recall that this was done in an era where the IVL balloon generator had a limited number of pulses. This has been extended, so I suspect this fluoroscopy time would probably be more equivalent. Predilation noted in both, obviously, by protocol as needed, and then embolic protection really in a very small number of patients. The number of treatment balloons, 1.6 in the IVL, 1.3 in the PTA arm. Again, this is related to an older generation of the IVL therapy. And the total number of pulses approached 250 per patient. You can see the procedural effort here, including maximum inflation pressure, much higher, 3 times that in the PTA arm over the IVL arm. Post-dilation occurred 1 out of 5 times rather than 1 out of 20 times in the IVL arm as compared to the PTA arm. And stent placement occurred about 1 out of 5 times in the PTA arm as compared to, again, 1 out of 20 times in the IVL arm. This is the procedural success. Again, results previously demonstrated showing the primary endpoint demonstrating superiority of IVL over PTA for the primary endpoint of dissection less than grade D or stenosis greater than less than 30%. Major dissection present, as you can see here, in about fourfold the PTA arm over the IVL arm. And if you look at the diameter stenosis, there was a meaningful advantage for the IVL arm over PTA in the entire cohort. Here are the final angiographic and 30-day outcomes. This really speaks to the overall results of the procedure, which will become important as we look at the 1-year data. And really what you can see is after all the effort to open vessels in both arms, the results were very similar. No difference between the residual diameter stenosis, acute gain, residual dissection, and at 30 days, safety profile was quite excellent with very limited MAEs and ABIs which approach normal in almost all patients. So here's the 1-year data. Primary patency at 1 year, again, a powered secondary endpoint, demonstrated superiority of primary patency with IVL over the PTA arm, as seen here in the left bar graph. If we look at the subcategories of these determinants of primary patency, you can see that the freedom from provisional stenting at the time of the index procedure was in favor of IVL, which we saw in the procedural outcomes. The 1-year freedom from clinically driven TLR was roughly the same between the two arms, and freedom from binary stenosis, again, roughly the same between the two. Secondary endpoints listed here, no significant major adverse outcomes in either arm. The ABI noted here, not different between the two in terms of the change from baseline. Rutherford classification, EQ5D, and WIQ overall score, not different between the two cohorts. If we do a multivariable analysis of predictors of 1-year primary patency, we see that the treatment group, that is IVL, gave an advantage over PTA. Age and CTO presence were disadvantages for the PTA group. We do have data out to 2 years. You can see here on a Kaplan-Meier analysis that the advantage that's seen both at procedure and at 1 year is maintained out to 2 years without any decrement in the overall differential between the two therapies. A pretty robust 2-year patency of 75% in what is one of the more complex lesion sets ever randomized in a trial. Heavily calcified lesions, calcium extending 13-14 centimeters and lesion lengths of 10 centimeters. So really quite remarkable results. So in conclusion, DisRUPT-PAD3 randomized controlled trial provides the largest long-term level 1 evidence to guide the endovascular therapy of heavily calcified popliteal arteries. The primary and powered secondary endpoints were achieved with superior procedural success in the IVL and then superior primary patency at 1 year with IVL. There were low rates of clinically driven TLR and restenosis in both arms. And these results are consistent with the results of IVL. But interestingly, if you look at historical data looking at PTA outcomes in even non-heavily calcified lesions, these results are quite a bit better. And it suggests that additional data are needed regarding the DCB effectiveness in heavily calcified lesions because there's some disparate data. DisRUPT-PAD3 randomized controlled trial demonstrates consistent safety and effectiveness of IVL treatment to facilitate a durable approach for patients with heavily calcified and femtopopliteal lesions. Significant reduction in bailout stenting with IVL preserves treatment options in claudicants with severe femtopopliteal calcification and limits the complicating features of any further intervention that might be required. Sahil, thanks very much for the opportunity to present these data.
Bill, thank you so much. That's a tremendous amount of data that really is going to change how we practice. Let's now talk a little bit together about what these data mean, and let's distill that for our audience. So, I mean, I think that if you have a safe and effective therapeutic option that allows you to have a reproducibly good result with a better both immediate and long-term or mid-term outcome, it's hard to argue that it's not going to change practice for many of us who are in this space. What do you think the impact of these data will be on the clinical paradigms that are now out there, the algorithm for care?
Well, I think it probably is going to reinforce an emerging algorithm, which is people are moving toward this therapy in both the coronaries and the peripheral, in the peripheral space. And seeing these 1 year and 2 year data, I think will again give some kind of underpinning of the therapeutic approach that we're using. You know, when you think about strategies that are dominant, in the case of this therapy, we have an excellent result, shorter work time, lower complications. That's a dominant strategy in my mind, and potentially less risky if you compare it to something like atherectomy. So these data, now that we have longer term reassurance of patency and safety, to me makes this a dominant strategy for calcified lesions.
Yeah, I mean, I think that's why this result is so important, is that it has important and sort of broad-reaching implications for the clinical algorithm that's now applied for patients that I would consider more of a real world than an IDE sort of population. And so it's I think, a spectacular result. What do you think is the take home about Disrupt PAD3?
If I have to summarize it in a sentence, I'd say that for heavily calcified lesions, intravascular lithotripsy results in excellent procedural outcomes with limited dissection and stent usage, with long-term outcomes which are both predictable and durable out to 2 years, especially when used in combination with DCB.
Well, there you have it. I think that's really the take home that most people will take as the headline. First, I want to congratulate you and Gunnar for a tremendous amount of work leading this trial. I was privileged to be one of the investigators, but in particular, the fact that it was completed during both the paclitaxel controversy and the pandemic, I think should be recognized as being a Herculean effort. I think that this is the first trial that I can recall, Bill, where we took patients who were expressly excluded from every other data set and were actually randomized head to head. Tell me what you think about the complexity of this patient population. And do you think it's quite possibly the most difficult patient population outside of a CLI subgroup that we've ever randomized for SFA disease?
Yeah, I mean, you stated it well. There's no question that if you look at the history of SFA trials, whether it's PTA, stent, or DCB, any of these patients would have been excluded from all of those trials. Calcium is a confounder in meaningful ways in terms of the ability to get to the end of a procedure. And for the balloon stent and DCB trials, we want to get to the end of the procedure so we can see what the patency looks like long term. And if you're limited by doing that because of dissection or inadequate balloon expansion, you can't do the trial. So the confounding feature of calcium is beyond description, and probably the most confounding feature in terms of what trial exclusions there are out there. So yes, I would agree that short of a 40 centimeter calcified CTO trial, this is probably as bad as it gets.
And to that end, I think when we think calcium, at least historically, we've almost always assumed that a scaffold would be necessary to get an optimal result. I think in my practice clinically, it would be at least a 50% bailout stent rate, maybe higher for lesions like this from the real world. What about your experience? I assume it's similar.
Yeah, it is. And I think, the options for calcified lesions really boil down to aggressive PTA therapy, some form of calcium-directed atherectomy, which is, long, complicated, potentially more adverse events and typically requires, especially in calcified lesions, some sort of distal protection. So it gets pretty complex pretty quickly.
Right. And you're adding on layer after layer of complexity. What would you say to those that say, well, PTA and DCB actually did really well with quite similar TLR? How do you put that in context?
Yeah, I think I alluded to that in my conclusion slide. I think it's interesting if you look at the historical data on DCB in the face of calcium and PTA. There's a mixed picture there. Finelli's data, which is probably quoted more than anybody's, shows that circumferential calcification and decreasing rates of it from there really do affect patency. Most of the studies that have been done are not randomized; they're observational, and they're relatively small. So this is the largest randomized data set, so we have to pay attention to it. A couple of comments about that. First is these are some of the most experienced investigators in the world, and we told them they have to get a lesion less than 30% with a balloon, and they worked hard to do that. And so they did, if they preconditioned the lesion pretty well, if you will, and I think that as evidence of that, they had a 1 in 5 stent rate because they got aggressive with this calcified lesions, trying to get to the 30% residual mark. And so we have greater dissections and greater stent implantation at the time of the IVL PTA randomization. And it necessarily confounds the 1-year patency when you have 1 in 5 patients who have a stent in one arm and 1 in 20 patients have a stent in the other arm. So you're now comparing DCB plus PTA plus a little bit of stenting versus IVL and hardly any stenting plus DCB. And I think both arms are terrific. Again, we kind of measured the effort it took to get to that point. And in the end, I think that, if you're talking about not leaving anything behind, if you're talking about the effect of IVL on the longer term patency without stenting, again, I think the conclusions are not different.
And so I think what I found refreshing about this was that the procedures were incredibly predictable in that the patient really got balloon and DCB to finish and not really to do the work, but rather just to drop the drug in at the end of the case. And that's the clinical strategy that I think that was examined here. Right, and the take home here is that the big difference was that the need for bailout stenting was essentially 15 percentage points different or thereabouts. And so for those of us that practice in a paradigm where leaving less metal or no metal behind is our paramount goal, this seems very clearly to be the superior strategy, lesion preparation, even in the most complex lesion subsets with IVL, followed by drug-eluting or drug-coated balloon therapy.
Yeah, I think that's right. If the goal is to preserve the native vessel without a prosthesis, I think this is the best first choice.
So in terms of your real-world practice, we've all been involved in the trials with the original IDE studies for drug-coated balloons where we selected patients who were cupcake lesions, but it was very difficult to find those patients to enroll. How would you characterize these patients compared to your real-world practice?
Yeah, certainly compared to the trials that came before it, these were much more representative of the type of lesions that we're seeing more and more every day, especially in the hospital environment, where the OBL phenomenon has peeled off a lot of the folks who are a little bit more straightforward, and we're seeing a lot of these types of patients. So it's comforting to see these kinds of data emerge in a population which is increasing before our eyes with an aging population, the diabetic, epidemic, as well as renal failure patients. So this is a population that's only going to expand in our practices, I think.
Yeah, and I would say exactly that. In my hospital-based practice, the percentage of calcium as a major constituent of the lesion subsets that I take care of is growing, and so this is much more reflective of my everyday practice than many of the other IDE studies. And to that end, the acute result seems to quite reliably and predictably give you comfort about what your long-term result is. And that was often something of concern to me. And I think the observational registry that accompanied this study, the Disrupt OS registry, gave us similar sort of acute results as this. Do you want to speculate at all about how we can now look forward to having this sort of reliable acute result predict long-term freedom from TLR and patency?
Yeah, I think that what you mentioned about the observational study is an important addition to this data. And as that emerges, I think, at least in our lab, the paradigm is going to be for the calcified lesion, IVL and DCB. To the extent that we need a stent, great, but it's in the single-digit range, and it gives a pretty reliable. Now we have 2-year data of almost 75% patency in a very difficult lesion subset, which is, I mean, if you had said this 5 or 10 years ago, we would have been jumping for joy. But this is a real deal in a population that's never been studied before.
Right. I mean, I think that's exactly right. That historical context is something that's incredibly important for us to remember, that these were patients we never would have imagined would have had these kinds of spectacular results. The acute safety that was earlier reported, I think, is quite astonishing. You talked about our use of rigorous and vigorous atherectomy with embolic protection in the majority of these patients. Here, that was almost unnecessary, and in fact, the complication rates were incredibly low. What do you think about those data? I think that's in part something that really leaps out at me as being an impressive advance here.
Yeah, I think most of us who heard about intravascular lithotripsy at the beginning several years ago wondered about the embolic complication rates that might ensue with that kind of aggressive approach to intravascular calcium. And that was as they asked me to get involved at the clinical trial level, I said, well, let's see what the embolic rates are. And I've been incredibly impressed with the safety, as you said, of this technology. Embolic complications are really de minimis and on par with standard PTA. And you can imagine that we're not doing anything to remove or disrupt the vessel architecture, but really more to modify the lesion set, that makes lots of sense. We're doing an in situ crack rather than a scrape and remove.
So that's exactly been our experience. At first we had done some of these study patients with EPDs just because we were learning how to use the technique, and then very quickly we fell away from any sort of that practice because we just saw such a great safety profile, and that's been incredibly reassuring. Because frequently when we were going to battle with these lesions in the past, we would have all of the gear pre-selected and ready. And it was almost unnecessary as we got more and more comfortable over the course of the trial. The other thing that was interesting was there wasn't really a training effect. With atherectomy and other techniques, it's quite operator dependent, I think, and technique really matters. Here, the technique is very simple and reproducibly effective in the hands of really quite disparate operators. Do you think that's a fundamental technical aspect of IVL, or is there something else?
Yeah, I think that it's a balloon on a wire. We're all comfortable doing that. There are some nuances that we actually reinforced during the trial as guidance for our operators, especially when you're overlapping balloons. You want to make sure the nodes are overlapped appropriately. And the markers which define the end of the balloon are not nodes, and so we have to make certain that there's no confusion about where the energy is being delivered. And again, the same thing has to do with being outside the treatment zone with a DCB. So we want to make sure that we cover the treatment zone with DCB. But those are nuances that we're all pretty comfortable with because we use DCB, we use DES, we know what the zone of injury looks like, and so there wasn't a lot of mismatch there. You're right. It's a balloon on a wire. That's a fundamental skill we all have. Predilation, interestingly, wasn't really necessary in more than a few percent of the patients, even those balloons a little bulkier. And so that's also fairly reassuring because we didn't need to do a lot of preparatory work to get the primary therapy engaged.
We look forward to seeing your manuscript in the Journal of the SCANI or JSCI, and obviously we expect that there will be lots of people with editorial commentary about how they're going to be modifying their particular algorithm for the care of these patients. We certainly are excited that there's now endovascular therapeutics available that really, for most claudicants and for more complex lesion subsets, rival and surpass surgical alternatives. And I think that everybody in the community can get behind that. It's a win for our patients, and it'll make our lives as practitioners a whole lot more fun. So,
Yeah, I agree.
Bill, I want to thank you for taking that time with us.
Yeah, and I want to thank you, Sahil and Jay Sky, for the opportunity, not only for the publication input and so on, but also for the opportunity to review these on video.
So, on behalf of Shockwave Medical and all of us who were investigators in the study and our principal investigators, we thank you for listening, and we look forward to hearing your feedback. Have a great day.
Thank you.